Hello, I welcome you all to this episode of Pediatric Clinics, an educative initiative for the benefit of the attending doctors. As you know, medicine is a dynamic science, and we have faced in recent past many epidemics which are related to either infection or immunological disorders, and we have battled them successfully. Recently, a new sort of epidemic we are facing in our day-to-day practice, and that is the one which is not related to infection or immunological disorders, and if we don't face it or treat it properly in time, then we are bound to end up with a disastrous result. I am talking of autistic syndrome or autistic disorder syndrome. And to throw light on this, we have with us a person who has treated thousands of patients in his practice and also has come out with a New Horizon developmental module to help recover the children from autistic disorders. And he is also a president of Mumbai IIP and a national chairman of neurodevelopmental chapter of Indian Academy of Pediatrics. He is none other than my dear friend Dr. Samir Dalwai. I welcome Dr. Samir. Nice to have you here.
Thank you.
And I'm sure a talk with you will enlighten our pediatrician colleagues to deal with this type of disorders which we are not used to during our medical days. So, Dr. Samir, can you tell us as to what is autism spectrum disorder and how they present in your clinic, and what are those subtle signs which we should pick up?
So, Dr. Parikh, I'd like to thank you for taking this initiative to take all this medical information into the clinics of our colleague pediatricians. As you rightly mentioned, developmental pediatrics is a subject which is coming up with a great importance in India, because as we know, the significance of infections and other disorders going down, but the incidence of developmental behavioral disorders is on the rise, probably because we are recognizing it and picking it up better now. You mentioned about autism spectrum disorders, and we know now that 1 out of 68 children or probably more are affected with autism spectrum disorders. And in our clinics today, it's very important that we pick up these signs, because we'll be increasingly seeing more children with these developmental disorders like autism, ADHD, learning disability, behavioral concerns, and of course cerebral palsy. So in my clinic, when I see a child, the parents usually come to me between 2 to 3.5 years of age. Their complaint is usually that the child is speaking late. And most people think that it is a problem with speech. However, we must understand that autism is a much more basic disorder than just a speech problem. And autism is a neurodevelopmental disorder which we know is now genetically manifested, which comes up with a clinical problem in the domain of development, and this domain is social communication domain. Gross motor developmental domain may be normal, fine motor may be normal, but the domain of speech, language, communication and social interaction is affected. The basic problem in autism is that this child is not able to communicate with other people or other human beings, and that happens because the child is not able to interact. So this problem starts from day one of life, because we know that normally a child will start looking at the mother, start recognizing the mother, and the first social milestone is social smile by 1.5 to 2 months of age, which actually tells you that the child not only recognizes the familiar pleasant face of the mother as a provider of the child's needs, but also can interact by smiling with her. And the child is interacting, and that is communication, where there is a meaningful interaction between mother and child. And of course the mother will smile back, the child will smile more, mother will smile more, so on and so forth.
So can I interrupt you, sir? What is social domain for everybody else to know? Can you simplify that by giving some examples?
So when we talk about communication, communication is an exchange of thoughts, ideas and feelings between two or more people, but in a meaningful, interactive, purposeful manner.
Yeah, so that meaningful and interactive is very important.
The most important thing, which probably the textbooks won't tell us, is the meaningful, the purposeful and the interactive manner.
Correct.
Because if we do not have this intention to interact and communicate with each other, it is not communication.
So when a child recognizes a mother and smiles, that is definitely a meaningful interaction socially.
Absolutely.
And that is the first sign wherein we say that child is developing well.
For that, you don't need speech. That's
Yes,
the point.
correct.
So even the child who has a meaningful social smile is communicating with the child. After some time, the child starts recognizing the actions of the mother, and after a few months starts responding to those actions. So the child responds to this sign, which probably has been bye-bye or come here. So these are what we call non-verbal communication.
Non-verbal communication, right.
So the child knows that I don't need to only keep smiling or crying, but I can also communicate using gestures.
So even when before child starts speaking, there is non-verbal expression which can be meaningful and interactive, and if that is missed, probably that is the earliest thing which we can pick up.
Absolutely.
That is the problem.
Absolutely, and you're right. Because if the non-verbal communication does not come up, the verbal will never come up.
Yes.
So what happens is that the child was initially only smiling and crying to interact, now understands that he can use some body language or some gestures to interact.
Right.
All these are non-verbal communication.
Correct.
And then as the child grows smarter and the cognitive power improves, the child understands instead of doing all these actions, if I make a sound to communicate this action, it's even easier for me.
Agreed.
So then the sound is produced which is meaningful. The baby produces sound on first day of life also, crying.
Yeah.
But it is not a meaningful word. And hence when the child finally looks at the mother and says "ai" or "mama" or "ma," that is a meaningful address to the lady that look at me or I want something. So we must understand that speech, which is only the verbal part of communication, is not separate from communication.
Correct.
But a part of communication. Just like sitting, standing and then walking are parts of gross motor development.
Yeah, so non-verbal as well as verbal expressions are very important.
Oh, absolutely.
Correct.
Because unless you have a good non-verbal, you do not have the foundation for a verbal. Just like the child cannot sit independently, can never stand independently. And again, besides non-verbal, verbal, the other way of looking at it is receptive and expressive.
Correct.
So the first thing is that the child will receive non-verbal communication, understand it, okay, this is what I can use it for, and then use it, which is expressive non-verbal. Similarly, the child will first receive verbal, understand it, and then understand that this sound codes for this action, and then express it.
Correct.
So unless the receptive power is good, the child will never have a good expressive power.
Agreed.
So this is what you wanted to know about verbal and non-verbal in communication.
Very nicely expressed.
Thank you.
So, Dr. Samir, from what you told us, I gather that autism spectrum disorder is the one where there is some problem or delay or disorder in way of expressing meaningfully and purposefully. And as you rightly said, a child who is born, once he starts giving social smile, recognizing mother, is the first sign of meaningful expression by a child, which may be non-verbal. So now, does it mean that any child who doesn't smile socially or doesn't express purposefully is always an autism?
That's a very good question. As we know, development is accumulation of skills along a time axis. So we know that there's a particular time for the child to sit, particular time to stand, particular time to walk. And if a child is only sitting but not standing at 3 years, I'm sure you will say it is delayed. Similarly, a child who doesn't have a social smile by 1.5 to 3 months of age, but may have it at 1 year, he may have social smile, but he has not developed the other milestones of communication that he should have developed by then. So we should also remember it is not only the emergence or the development of the milestones or the appearance of milestones, but also at the time in which they appear.
Is there something like, say, a repetitive movement or maybe delay or deviation from your normal development which will add to the definition of autism? Alright,
that's again a good question. So when we say autism specifically, what do we mean? We mean that there is a disordered social communication domain. When we say disordered, it doesn't mean only a delay, it also means a deviancy. By deviancy we mean that this child is not normally developing communication, non-verbal, verbal, receptive, expressive, not only as per the age which is delayed, but is also developing it differently. So at a younger age, maybe by 1.5 year of age or 2 years of age, a child may repeat certain words that he hears. So that is not a deviancy, but if the child continues to repeat words without meaning, and if you ask the child, what is your name? And instead of answering, the child repeats what is your name, which is non-meaningful.
Yeah. So
Which
it's
is
almost like a parrot-like.
It's parrot-like, non-meaningful.
Non-meaningful, right.
If I have not heard you clearly and I repeat your question, that's a meaningful repetition.
Correct.
So that is not echolalia.
Yeah.
But meaningless repetition without any furtherance of communication is echolalia.
Okay.
So this is a deviancy.
Yeah.
Similarly, since children who have a problem do not know how to meaningfully use sound, they will keep making sounds which will have no meaning.
Correct.
So we call them neologisms or nonsense words or jargon speech.
So echolalia and neologism,
So
these are very important.
These are very important parts because there are deviancies.
Correct.
A normal developing child who is merely delayed will not have these deviancies.
Yeah.
The third very important aspect is joint attention. Now when the two of us are communicating, and if I am able to only communicate between two people, then I can only learn from you. So similarly, a child who can communicate only with the mother or father will only learn from them. But the mother will then say, look at this is a cup of tea. So then the child will look from the mother to the cup of tea and focus on the tea while the mother is telling him about the cup of tea or whatever, and learn about it.
So he is following the gaze of the mother and looking at the cup which mother is pointing.
That is joint attention. Why is that important? Because if I don't do that, I can only learn what the mother is teaching me, and I will not learn about other things. So joint attention is
It's a very important aspect.
It's extremely important in our cognitive development, because joint attention is again exchange of thoughts, ideas and feelings between two or more people about a third person, object, idea or thought. So if both of us sit here and discuss about Ghalib, for example, or we discuss about William Wordsworth, they are not there in this room, but I can learn about it because you are telling me about him, because I can jointly have. So it's not only following your gaze, which is what is seen very easily, it's also linking with you about a third idea. But a 9-month-old child should be able to follow the gaze of the mother once engaged. If you look there, I should be able to follow your gaze and then look back at you to complete it. So that is what is joint attention.
So if that is disturbed, then you have a subtle sign.
That is the very important deviancy that you can pick up. So deviancies like echolalia, neologism, lack or development of joint attention, these are very important deviancies which by 1 year will be picked up. So this is a social communication domain, the social interaction domain. Also you mentioned about repetitive behaviors. So we see children who have only problem with social communication, the diagnosis that is now used is social communication disorder. In addition to social communication disorder, if this child also has repetitive behaviors or restricted interests, then the diagnosis is autism. So let me tell you what is restricted interest. Typically, if we have a toy car, the child will look at the toy car as an object and pretend to use the whole car for the purpose of which you use a real car. A child who does not do that and only is fixated or gives interest only to a part of the object, like the door of the car, or turns the car upside down and only plays with the wheels and rotates the wheels, is not understanding the concept of the car as a whole, but as a restricted interest only in a part, only at the wheel, which does not signify the car. Now that is called restricted interest. So you would have a child who probably comes to your clinic and would probably only try to play with the pen that you have in your pocket, or only one thing in the whole room, maybe only the fan. So that is restricted interest. What is happening is that he is cut off from understanding about the other aspects in the room. And the other part is repetitive behaviors. So you have some children, just like you have echolalia, which is meaningless repetition, they will keep doing meaningless actions again and again. So once in a while, if somebody does this, it's meaningful. But if somebody does this meaninglessly, it's what we call a repetitive action. So repetitive restricted behaviors along with social communication disorder is autism.
Dr. Samir, other than these repetitive or restrictive or joint attention or meaningless actions or maybe discordant actions, is there something which we should give importance to, say, like for example eye contact? What is the importance of eye contact?
That's again a very good question. I have many children with autism who have excellent eye contact as perceived by their parents. But even eye contact, we described, anything in communication has to be meaningful, purposeful and interactive. So if somebody is just blindly staring at you without any meaning, it is not meaningful eye contact. So a lot of parents come to us late because they have read somewhere the child will not have joint contact, will not have eye contact. But it says my child has eye contact. Why eye contact? Parents come to us very late saying that my child was talking. He was saying mama, 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 and he was calling me out. But when you go back in the history and you ask whether he was only looking at the mother and saying mama, or he looked at the father also and said mama, he looked at the auntie also and said mama, he looked at this cup also and said mama, he looked at the wall and said mama, then that mama is not a meaningful word.
Excellent, yeah.
So very often we get confused because it's seen as a regression. But in my practice, I must say with some degree of responsibility that I have not seen a lot of regression as much as is reported in literature.
Okay.
Because if you go back and take the history clearly, these were not meaningful words.
Okay.
So I don't take that as a milestone have developed and now gone away.
But from the beginning it was meaningless.
It was meaningless.
So it was probably an early sign which should have been
Yes,
picked up.
which is important because if you really have regression of developed true milestones, then you are looking at a rather than a neurodevelopmental disorder, you are looking at a neurological disorder,
Yeah.
which is regressive, and that is something which is quite sinister, and you need to work it up
Correct.
more aggressively because that has a bearing on the child's life as well.
Yeah. So now, after listening to you about all these things, can you give us some simple examples of autistic children which have come to your clinic when they have come early in the right time, what were the presenting symptoms, and when they came late, what were the presenting symptoms?
Okay. So I have had children who've come to me at 1.5 years of age, which is excellent, referred by somebody like you who understands the basics of child development and can refer, and the same things. So the mother would even ask, isn't it too early for my child to have speech? I said, yes, you're right. Too early to have expressive speech. So I will ask her whether the child's receptive speech is okay. And then I will ask the mother, does he follow instructions which you give? So by 1 year of age, the child should be able to follow one action command. One action command would be, for example, where is your tongue? So child will stick out the tongue. Or show me your eyes. The child will do something like this. Or take this pen. The child will be able to take that. But it's wrong to, kind of push the pen in the child's face and say, take it. That's what people do.
Yeah.
But the child will probably be visually seeing it and taking it. So typically you may have to even cover your mouth so that the child doesn't lip read and just give that command. By 1.5 years of age, the child should be able to follow two action commands. Take the cup and give it to mama.
Yeah.
So he understands receptive communication is good, receptive verbal, and he'll be able to do that. By 2 years of age, he should be able to follow three action commands. Take the cup, go outside the room and give it to mama. So generally parents get confused when they come at 3 years, they would say that he's following commands, and I will ask them, what sort of commands? So it's very important for our pediatrician friends to ask this in detail.
Yeah.
What commands? I tell the child, show me your eyes, and he does like this. At what age? At 3 years. So I have to tell mama, this is normal at 1 year, not normal at 3 years. So when we find that out that the child not only has delayed expressive verbal but has delayed receptive verbal, then I go back. Now I test for non-verbal. So I ask the mother that does your child use meaningful gestures like this for food, this for water, this is for phone, so on and so forth. So she will say, if she says no, that means the child's expressive non-verbal is also not developed.
Yeah.
Then I would ask, does he follow your actions? When you do this, does the child understand what it means? If you say, make this, does he understand? So he may understand some, he may not understand. Which means that is non-verbal, receptive is emerging at a time when we should have expected very good verbal expressive. So similarly, verbal milestones are at 1 year. The child should be able to say one meaningful word. By 1.5 years, he should be able to put two meaningful words together, like water, give. In whatever is the language vernacular at home, it could be Marathi, Hindi. In Hindi, we would say pani do. So it doesn't matter if he says do pani or pani do. Grammar is not important at 1.5, 2 years of age. But the fact that my child's brain can link two meaningful words together to make a third meaning, give me the water. And similarly, at 2 years, he should be able to put 3 words together to make a meaningful sentence. So these are the guidelines, but even by 2 years, if the child has 2 words together, it's okay.
Yeah.
But the child does not have a single meaningful word by 18 months, by 1.5 years, that's definitely a red flag. So we need to counsel.
Like say for example, child is developing milestones wise absolutely normally, but he has a delayed speech. Sometimes there is a physiological delay in the speech. So how to differentiate that from the one which you told us?
Alright, that's again a very good question, because there are many parents or maybe grandparents will come and tell you that we have seen many children who spoke late and they are fine. Like this child's father spoke late, but he's fine. Now the point is, we get confused at this issue because we don't take the complete history of speech development. If you have a child who has very good non-verbal interaction, both expressive and receptive, the same child has very good receptive verbal. So if you tell the child a command age appropriately, he is able to follow it. Like a 2-year-old child, you give a 3-action command, he is able to follow it. But he has only a problem with expressive verbal, and he does not have any other problem with eye contact, with echolalia, with neologism. He has good joint attention, no deviancies. So you have this kind of a group of children who have a problem with exclusive, specific, isolated, expressive verbal delay.
Otherwise, it's absolutely normal, non-verbal
Yes.
communication wise.
Correct.
Then we are sure that it is not autism.
It is not autism.
Correct.
So this is the child in whom you will not suspect autism immediately, but there's still a caveat. Just let me complete this. Every child who has a problem, even with only expressive speech, you have to get a hearing evaluation done.
Correct.
Because there are some children who have a hearing problem, so they will have normal non-verbal communication, but they'll have a problem both with receptive and expressive.
Correct.
So typically they would not be able to have a good receptive verbal as well, but some children lip read.
Yeah.
So if you have a problem with speech, one thing which you cannot avoid is getting a good hearing evaluation on a machine. So just shaking that rattle and testing is not the right. You have to do either a BERA or a VRA or an audiogram.
Yeah. So here I can say that parents are commonly their complaint is that my child is understanding everything very well. Though he is 2 years old, he is doing everything what a 2-year-old child should do, but he cannot speak. So here, as you say rightly, first we should look for the hearing, and if that is normal, then probably this is a physiological delay, and he may come up with the speech a little later, but this is definitely not autism.
As long as he has normal, non-verbal interaction and communication.
Correct. Yeah. Now, can you give few more examples? This is not autism, though it looks like autism, but it is not autism.
Okay. Well, there are a huge number of children in our country who are exactly fitting what you said, Dr. Parekh. A lot of children today have a problem with communication because the communication that they have learnt is itself abnormal. And I'm talking about this child who after 2-3 months of his born is either left in a creche or left in front of the electronic nanny or babysitter, which is a television.
Yeah.
And I see so many children who come to me today who have what I would initially feel is disordered social communication development. They just do not have a good eye contact, they will look away, they will not engage with you or interact with you, they will have some abnormal speech. But then when you look at it in more detail, they are just mimicking some animation that they are seeing. And you and I don't see so much of animation, so we don't know whether he is copying Doraemon or Shinchan. But we see a lot of children who have a problem because if you don't let a child sit on the ground, he is not going to learn to stand and walk. If you are carrying him around all the time, we know the child will have delayed walking.
Yeah.
Similarly, if the child does not have good human interaction, there are no people around addressing the child, speaking to the child, then he will have a problem with this. So a lot of children who come to me have been exposed to only television and the tablets and the phones all the time, and they are hooked onto it, and they do have a problem with establishing social contact. So every child who comes to me, while I'm evaluating him for autism, if I think so, I make it a point to tell the parent, please completely switch off the screen. So no screen time, which means not just no TV or laptops, but no mobile, because every child I see now is hooked onto the mobile. And very often by the time the reports are through, which takes about a month or so, the child comes back and the parents say he's doing all right. So my caveat is, don't make that the first diagnosis, that this is because of the media. Always look at a detailed evaluation, get a hearing evaluation done. But in any case, tell the parents to switch him off the media. Because we lack today because of nuclear families, sometimes both parents working, right, a couple of months after the child is born, no grandmother, mausi, chacha, chachi around. So children do suffer a lack of that.
Yeah, and then looking at those cartoon serials, they take Donald Duck or somebody else or Bhim, Chota Bhim as their own idol.
Absolutely.
They start behaving like them, where there is not a natural behavior, but it's a fabricated behavior.
It's fabricated behavior.
And then they start behaving like them, and then we feel that this child is maybe abnormal. But then if you go into the detailed history, how the child has been brought up, whether he's in a nuclear family, whether he's left in a creche, or whether he's being looking at always the information media, TV, mobile, and then you can end up in wrong diagnosis. So I think this history is very important.
I'm going to copy your word, fabricated behavior. That's very nice.
Yeah.
Again, the caveat is don't just brush it away as saying that this is only because of the media exposure, because every child will come to you with media exposure. First, rule out the other aspects on a very good history, and only then you can think about it. But in doubt, we know that if we start early intervention, we can have a tremendous improvement. Hearing impairment, for example, if it is diagnosed before 6 to 8 months of age and you get a hearing aid put in by 6-8 months of age, the eventual speech development is almost normal. But if you pick up a hearing impairment and put in a hearing aid by around 2-2.5 years of age, the child may be able to hear, but the speech will never ever come anywhere near good. Similarly, if you have a child with autism, if you pick it up early and if you start with a very good intervention program, the outcome for the child is amazing. So I would always say, don't just brush it away saying that it is normal, or boys speak late, which is a wrong myth again, or his father spoke late so he will speak late. All this is not the way to do it. Similarly, don't just lump it on the media and send the child away. The other thing I'd like to share with you, I get a lot of patients from the Middle East and now even from the country where both the parents are, different mother tongues, interstate marriage, and then there is a servant who speaks another language, and then the television is another language. You go to school. So typically, say in the Middle East, you would have all this. If you go to a school which has 180 different nationality children from 180 nationalities. So very often the parents would come and say, is this because everybody speaks a different language? And my answer to them is, in which case every other child in that city should be doing the same. But the other children are not. Only your child is. So though the fact remains that if there is too many languages around, the child with autism will in fact have an even bigger problem. So that's good, because he should be identified early actually. So this is very important to pick up, that it is not because of differences in language. A child who is a normal child will in fact pick up all these languages, and his non-verbal will anyway be normal. He may have bad grammar. He may mix a word of Hindi, Marathi and English in one sentence. The grammar is okay. His pronunciation may be a little bad, but his intention to interact and communicate cannot be bad.
So it's a very important point. So can I put it this way, that when you suspect autism, wherein you feel that there is some problem in social domain and is not communicating well verbally or non-verbally, and you have ruled out hearing problem, and also you have taken detailed history of whether child is left alone, not having any human interaction, is looking more at TV or not, then you can say that okay, everything else is alright, and there is some repetitive behavior, there is some deviance, some delay, and there is some abnormality in communication, then you suspect autism, rather than going into the straight diagnosis of autism. Now, as you said while introducing autism, that it's a genetically predisposed disorder. So how much common it is in the families? If there is one child with autism, is there a likelihood that other child also will suffer from the same?
Absolutely. If the first child has an autism, we know that the second child has 10 times a greater chance of having autism as well. And now, as the entire science of genetics and the human genome has been decoded in the last 5 to 10 years, we all know that all of us have a unique, like we have a unique identity number, we all have a unique genetic code. And now, since it's possible to study, there are hundreds of genes which have been identified to be associated with an autism-like spectrum. We know that the commonest genetic abnormality which is identified in children with autism is Fragile X. And I have seen a lot of many children with trisomy 21 who have features of autism as well. So we don't have an autism gene, but we have a spectrum of genes now which are associated with autism. But what we see is for sure is there is definitely the problem of autism, like Leo Kanner described 70 years back. It is something that is inherent from birth. It's not something that comes in from after birth. As much as it is something which is, so obviously we are looking at a genetic cause. I mean, it's not like obviously an infection, a malaria or a tuberculosis that you get postnatally. So if you look at the timing at which autism sets off, then we suspect that it has something to do with the genetic code itself.
So now, knowing that there are 10 times higher chances of other sibling having autism when you have one child with autism in your family, can we prevent it?
That's again a very good question. So we haven't got to a level in science where genetically you can modify it. But we definitely have reached a level where, for example, if you look at Angelman syndrome, we know for sure that it is the 15q chromosome which is maternal derived. So now we have started identifying the site at which it is located. Again, in Angelman, for example, there are 3 or 4 different genetic mechanisms by which you get a baby with Angelman. Now, some of these mechanisms will repeat in every baby, and some may not repeat in every baby. So you need to not only identify the previous child but also the mutation in the mother, and try to find out whether it is a repeatable mutation or it was a one-off mutation. So we've reached that level, but of course not in all children with autism. The other thing which I am currently, my center is working on as well, and many other people across the world, leave the genetics aside. If you finally do know that you've gone ahead and you've conceived and you're going to get the next baby, and you are at a risk for having a baby, which is like we mentioned. So for parents, we feel that if you have conceived and you are at a higher risk for child, we know that it is a genetic as well as an epigenetic theory which is involved, that you have the genes, but the environment also has to go along with it to have a double impact for the child to manifest. If we know that it is a problem with social communication, and this is what our team is working on, if you can train the mother to be more interactive, to be more communicative, to get more involved and engaged with the baby, then I'm sure that even if the child has a genetic predisposition for it, the effects will be mitigated. Because if the child lacks the genetic mechanism to interact, but if you overcompensate for it, eventually it will help the child communicate better. Because after all, whatever we do for a child at 2.5 years in terms of early intervention is not to give him an injection or some surgery, but to interact with the child and to teach the child interaction. So what we are saying is, why don't we prophylactically start engaging and interacting with the child more from day 1 of life? And maybe if this child was to manifest as autism, at least the effect or the magnitude to which he would affect is obviously good, because that's the earliest intervention that you have started on day 1.
So probably this gives a ray of hope.
Absolutely.
To the parents, that even though you have one baby with autism, you can go ahead with another baby,
yes,
but with this type of precautions and more of human interactions to prevent the manifestation, or maybe the
magnitude
level,
yes,
magnitude should be controlled.
That's right.
Okay, so now, okay, we have an autistic child in the family. So does it, or rather we should take this child as a burden to the family or to the society, or he can be useful to the society?
Well, I think if we do not deal with our children correctly, whether they're autistic or non-autistic or whatever, that's what decides the difference between whether they're useful to society or a burden of society. I've seen children who are brilliantly genetically endowed but who go on to become a burden to society. We can share some examples. Yeah. But if you look at a child with any developmental disorder, we have a very different way of looking at it, and that's the New Horizons developmental program that we have looked at. What we see these disorders as is not the presence of an abnormality, but as the absence of normal development. Okay. So if you bring a child with autism to me, I will not look at all the abnormalities that he has, but I will look at what are the social communication domains or milestones that he has already developed normally. If I take that as X, I know what is X plus 1, because we all know after sitting comes standing, then comes walking. Similarly, we know that if after meaningful eye contact, you will have non-verbal communication, first receptive, then expressive, then verbal receptive, then expressive. So what we will try to do is we will try to work on strengthening the milestone at which the child already is, and encourage the child to go on to the next level of development. So this cannot be like a rigid rule, but we need to help the child to do that. And this works very well if you have a very young child. So if you have a child at about 2.5 years of age, I have seen in my practice that this works very well. So instead of labeling the child as having a disorder, you look at what the child has already developed normally and work at that level to go ahead. Which is where I must make a very important statement. Because the parents feel, or the parents recognize autism as at a time when the child is supposed to speak and is not speaking. So that's when all of us kind of realize that there could be a problem. So speech, we think, is the important issue. But as we have discussed, it's not speech. Unfortunately, many of our colleagues would still refer the child to a speech therapist.
Correct.
But unless the child's previous levels of development are completely normal, there is no point going on for speech.
Yeah.
So what we as pediatricians, as people working in this field, as occupational therapists, physiotherapists, speech and language pathologists, all of us need to recognize that it is not part of our only one academic domain or only one professional domain.
Yeah.
It requires a holistic developmental approach to start at the level at which the child is. So when we do this in our clinic, we make a 6 months program, because if you know X, you already know what is X plus 1, X plus 2. And then you put together what are the various therapies which are needed to take the child from X to X plus 2 over a fixed period of time, say 6 months. Then you need to document it, because there are so many stakeholders involved, we can't just remember it. So we need to document. And then we need to decide what kind of therapies he needs on a month-to-month basis. So if it's like a chemotherapy regimen, if it's written down, if it's documented, if there's a protocol, and if we follow the protocol, then we can measure the improvement. And anything that you measure, you have a much higher chances of making it succeed.
Yeah.
So I think if we do it in the way as you mentioned about New Horizons developmental program, it's exactly a goal-oriented, time-bound, multidisciplinary, interactive, dynamic, documented program. So anybody who does this, I'm sure you'll see the child doing very well. And once the child starts achieving milestones, he's just like any other child.
So, Dr. Samir, after talking to you so long, now I will like to ask you, as a neurodevelopment pediatrician, which age group should come to you with probable autism for better results, and how they are managed?
So if I'm looking at being referred, the child being referred to me by a pediatrician, this is what I'd like to suggest to my colleague pediatricians. First and foremost, if you have a child, a parent already has a child with autism, automatically, even when the child is born, you need to recognize that this child is at a risk for autism. Just like if you have a child who's in the NICU, has a STOMI NICU course or perinatal course, you know that he's at risk for cerebral palsy. So you have high risk features, the biggest one being that a previous child with autism or a history of autism in the family. So you know right at the beginning you need to monitor this child. We have already discussed clinically the importance of assessing and understanding communication by pediatricians, so you can pick that up. But an even simpler way, once you have understood, is you can use a screening tool like an MChat, which is available to download off the net. My suggestion is, when we talk to pediatricians about using MChat, they should be first explain what are we looking for.
Yeah.
And that's why we have a very poor rate of pediatricians using these screening tools, because they haven't really understood the significance of how to do it. So after having understood this, I think it's very important that if you are in a doubt, use a standardized tool like an MChat, and there you go. And if you then feel that there is a problem, first thing that a pediatrician can do is anyway get a hearing screening done. So that's the simplest thing. Second thing is, please realize that it is my patient. Every pediatrician should understand whatever is the level of autism, the patient is mine. I am responsible for him. So if I need to refer him to Dr. Dalwai, that's fine, but the patient is mine. It is not Dr. Dalwai's patient.
Correct.
So if you refer the child back, you make sure that you continue to be the primary healthcare provider to the child. The other reason also being that though the child may have autism, which I may have to specifically work with, he's still a regular normal child.
Correct.
He needs to have vaccination, he needs to have all the immunization shots given, he needs to be looked at for his cough, cold, fever, vomiting, infectious diseases like every other child.
Okay.
And very often the challenge is, it's very difficult to pick up why a child is crying in any case, and especially so a child with autism. So you need to understand that I don't want to cut off in my mind the child because he has autism. I need to look at his health concerns in any which ways. And then when you refer to the developmental pediatrician, make sure you refer to a person who will document whatever he has seen. And if you refer to other specialists, make sure that they all send you a report of what they are doing with the child. And you should be the person in the center who discusses and counsels the parents as to why they need to do all of this.
So I get it that it's a teamwork. So we should be referring to a neurodevelopmental pediatrician who has a team at one place under one roof. So the documentation is very important, and they can communicate with each other very well, and they can see the impact of what they are doing. That is very important. I get that. But then, from the previous discussion which we had, I gather that age maybe around 2 years or 2.5 years, when he's still developing, if they come to you,
Yes.
you can give better results.
Yes.
Anyway, Whenever you diagnose, you have to refer
Yes.
for better prospect. But if you refer at a right time, say about 2 years, then you can have a very good result.
Yes.
That is what I get. Am I right?
That's right.
Yeah, that is one. Secondly, if this child is managed in your clinic, what exactly the steps 1, 2, 3, 4, what you do when an autistic child comes?
Yes. So the very important statement that the American Academy of Pediatrics has made, and it's a guideline, that you don't need a definitive diagnosis of a developmental disorder to start early intervention.
Okay.
Because unlike tuberculosis, if you don't diagnose and give a anti-tuberculous treatment, we know that it has side effects. But the basis of treatment of developmental pediatrics is developmental therapy. So you are only trying to improve the child's level of development. So you cannot ever have a side effect, or you cannot go wrong. You can only help the child to develop better.
Yes.
So if in doubt, refer and start with early intervention. Now when the child comes to a developmental center, we have a 6-step process. But to tell you in short, I would see the child first. I would look at the history, I would look at the evaluation, the examination of the child, and then I would ask for certain evaluations. I would ask for a developmental quotient, I would ask for a CARS, or I would ask for an ISA or an INCLIN, and look at an ADI or ADOS and look at a diagnosis. At the same time, I will like to involve my clinical psychologist, my occupational therapist, my speech and language pathologist, depending on the stage at which the child is. If it's an older child, I may even involve my remedial educator. But it's very important to understand that all of these are disciplines in their own right. They may not have an overall holistic picture, which then the developmental pediatrician needs to have. So the developmental pediatrician is actually the director of the film. And then you need to get various actors to say act out their roles according to the script that you have written down. So you need to monitor that the child gets these kind of therapies what are required from time to time with continuity, and you keep monitoring the targets, whether the child is developing the skills in a particular time bound fashion. And that's basically what you need to do for every child.
Yeah, this told. Now can I know that are there any medicines which can be useful in the case of autism?
Alright. So again, before we go to the medicines, if you look at the evaluations, a lot of times we need to not do an MRI, because unless you have got focal neurological deficits or you are looking at a particular neurological disorder, you would not need an imaging. Similarly, in EEG, I would restrict only for children who have seizures, maybe subclinical seizures or sudden behavioral changes. Genetics, as we discussed already, there are various tests which are coming up now. But the audiogram or the hearing evaluation would be the elementary test. Looking at the medications, there are no medicines that affect the core features of autism or of ADHD also. But there are medicines which help us control certain symptoms. For example, for me to give the child therapy, if he is very, very hyperactive, because there are a lot of children with autism who would have a comorbidity of ADHD, attention deficit hyperactivity disorder. So if the child is not at all willing to sit in for therapy and the therapist has no breakthrough with the child, I would want to curb the hyperactivity of the child, for which I would consider a methylphenidate. There are some children with autism who have a lot of aggression. I would consider risperidone for that child. There are many children with autism who have anxiety or repetitive behaviors. And we know now that fluoxetine acts very well on all of this. So I would use these drugs in my practice in conjunction with a larger developmental program. But the biggest drug, I think, which is very important, is counseling the parents. And that is the most important basis of management, because parents go through all these stages: refusal, denial, anger, grief, and then you know all of that. So you need to be partnering the parent through all of this, and you cannot just kind of give a prescription and end it, because parents do not, the child looks physically normal.
Correct.
So it's very difficult for the parent to accept that there is something abnormal with the child, especially at an earlier age, say at 2.5 years. It's very difficult for the parent to accept it. So what we always say at New Horizons is that we have a concept which is from label to enable. Don't fight with the parents to establish a diagnosis. You don't need a label or a stamp. You just need to tell them that these are the problems your child has. We need to work with your child to get him better. And I think that's where the entire strength of counseling lies.
So it is very difficult for a parent to accept that his child has autism. But if you can tell them the difficulties which he is facing,
Right.
and then we can do counseling part more importantly, which will help him.
That's
so
right.
in management, counseling forms the milestone or cornerstone of
Yes.
the management, and other medicines maybe to control the comorbidities,
Yes.
which will help
Absolutely.
in treating autism.
Absolutely.
I gather that very nicely.
Very right.
Now, have you seen any autistic child recovering completely?
All right. Now there is a little bit of irony to this. We know that the child before 3 years of age, the brain is very plastic, especially before 2 years of age. So most of the diagnostic tools which allow us to give a label and a final diagnosis are after 3 years of age. The children which I am fortunate to get now, if I get somebody around 2.5 years of age, we again not label them, but we consider them at risk for autism. So if I see the child clinically, I would feel he's going to be autistic, because before 3 years I can't say. Now if this child you work with very intensely in the way I mentioned, so you have therapy sessions in a planned programmed manner for the child, and you tell the parent to go home and copy it for about 2 hours every day, and he gets about 20-25 hours. I have seen about 90% of children whose parents follow this very rigidly, giving the child time, cutting out the media, doing the therapies, following it up at home for 2.5 hours. Almost 90% of children in our clinic do very well, that by the time they reach 3 years of age, if you then use a diagnostic tool, they may not score. So here, I can't say that you diagnose a child at 3 years and then you may not have that amount of success, which is why the diagnosis comes at a time when you know the child is not going to improve, that you are surely labeling him.
That is very late.
That is very late. So the whole fundamental is that if you work with the child before, you have phenomenal scope of getting the child all right. The key issue is doing it very methodically, professionally and rigorously with the parents on your side.
Impact.
And yeah.
Are there any vaccines which should be avoided in case of autism?
Well, there was this huge controversy, but we are very clear now. All evidence has shown that vaccines do not have anything to do with causing autism. That's the research that has come up now.
Can this child of autism marry when he becomes adult?
Yeah, well, so like we spoke at the beginning, this is a spectrum, and by spectrum we mean that the clinical manifestation varies between different children. I would say the clinical manifestations vary in the same child also, because every few months that you're working with the child, if the child is getting better, then it's a spectrum within that child himself. And our slogan at New Horizons is every child can do better compared to yesterday and not compared to another child. So if you keep working on this, if the child is able to communicate, is what I've largely felt, if the parents are able to deal with that and help the child communicate, and very importantly, like any human being, if you do things which allow the child to do things which give the child happiness and make the child confident that he's contributing, I've seen a huge change in children the moment. For example, there would be I have this child with me in one of my clinics who is a chef. He's 9 years old, but he can rattle out all of the recipes of any dish that you want. So I've kind of taken a video of this child and we've made a YouTube channel and we've put him on it and we call him Chef XYZ. And he already has so many YouTube hits. Now the moment he sees appreciation from so many people, so far he's been shouted at in the school, he's been abused, he's been insulted, he's been made to look like he's an abnormal kid, he has to come for therapies, he doesn't like. But finally, one place he sees a lot of appreciation, the happiness which he gets motivates him so much that suddenly he is able to do so many things. So this is the most important thing. The moment the child feels some self-worth, we see a completely new child. And if we are able to do that for the child, and not, unfortunately, a lot of parents are still focused on education and academics. But if we are able to recognize that every child has certain things which he is well endowed with, and you do it, it gives the child so much of confidence that he can improve in all other domains as well. So surely this child can go ahead, he can lead as normal life as possible, as much as we can integrate with him, and I'm sure he can go on to have a normal life as well.
Normal life also. Do these autistic children require to go to a normal school or a special school?
Well, I would say the other way around. If my school is equipped to handle this child, I should be able to deal with it.
How to identify that school?
So I give the parents an example. That if your child is swimming in a swimming pool, when will you ask him to go to the ocean? Or when will you ask him to jump into the sea and swim? So the school or the classes, even parents ask me, should we go for junior KG or senior KG or class 1? My answer is, it cannot be according to the age. It has to be according to the child's level of development. So the way I put it to them is, if you think your child is ready now to swim in a lake instead of the swimming pool, that is the time you will take him to a lake. When you feel he is good enough in a lake and he can go to the river, you put him in the river, and then finally in the sea. So parents need to understand, let me go and look at this particular school I have in mind. What are the facilities given in this school and this classroom? Can my child adapt to them? Because if they are far away from where my child is probably going to feel worse. So let me put him in a level of classroom or a type of school wherever it is conducive to him. So today we have so many preschools. Now not all of them are very rigid about criteria. They are willing to take in a child, they have smaller number of children. Sure enough, there could be some schools which have 60 children in the classroom. They don't have resources to deal with what the child needs. There's no point sending a child there. So it is an individual decision.
So in short, when a patient of autism comes to a general pediatrician and he asks which school to go to, we can tell them that a school where there are facilities, there is no rigidity, smaller number, and teachers are very empathetic and tender to the child,
Yes.
lovingly taking care of the child. I think you can try there and then see whether your child adjusts or not, and accordingly you can decide.
Absolutely.
Right?
Absolutely. We are the third pillar.
Yeah.
The parents and the school are the first two pillars. We are the third pillar. So we as a developmental team need to integrate not just with the parents and counsel the parents, but also with the school. Because the school, the teachers are not equipped to know this in detail. So they are always scared. So when we write to the school or when we talk to the school teachers and we assure them that if you have any problem, call the parent, but call us also. We will be there to help you. So if you give the schools this support, that don't worry, we are there to support you on certain special issues. The schools are also quite willing.
Thank you very much, Dr. Samir. You have given an excellent outline, maybe, because this talk can go on and on, but for a pediatrician to know what exactly is autism and how to deal with, you have given an excellent picture of that. And I can say that it's a neurodevelopmental disorder if picked up early by a general pediatrician or parents, or if there is an history of one child having autism, the second child is brought to a neurodevelopmental pediatrician in time, and when the brain is plastic and you start acting on it, and with a team, dedicated team with proper documentation and impact study, definitely a autistic child can do much better and can be a part of the society in a positive manner.
So, Dr. Samir, it was nice talking to you, and me in particular, and the listeners in general have really come to know about autism in a much better way. To just let you know, as a Honorary Secretary General of Indian Academy of Pediatrics, I can tell you that the guidelines which are published under your leadership by Neurodevelopmental Chapter of Indian Academy of Pediatrics are going to be published in the next issue of Indian Pediatrics, and I'm sure all the pediatricians can take up this issue, and all these new students who have passed their MD or DCH or diplomas can take up this particular field of pediatrics by getting themselves enrolled for the fellowships which have been started for this particular topic. We definitely need many more developmental pediatrics in the society, and you can definitely play a very important role in helping the parents in recovering this child from autism. Thank you very much, Dr. Samir. Yeah.
Thank you.
Yeah.